Okay, good afternoon. So today's meeting of the HHC Accountable Care Organization sole member annual meeting is now called to order. Please note for the record that Dr. Sheri Shamani is representing Dr. Dave Shoxi, Scott French representing Stephen Banks, and Philip Wadley representing Deputy Mayor Melanie Harsog, all in a voting capacity. So let me move to then presentation by Mr. Ziegler, update of activities of the ACO.
Great. Good to be with you all. Thank you for having me. I'm joined by Dr. David Stevens, our Chief Medical Officer of the ACO and Head of Ambulatory Care at Kings County. And we'll take you through our results for 2020, some of the projections for 2021, and some of the key clinical activities that we're working on this year to improve the health of our ACO patients. So next slide. We will come back to this. This is a resolution on the board of directors of the ACO. We'll just jump right into the 2020 performance results. So we have finalized these with CMS, and we will be making the distribution shortly. But the takeaway is that the ACO has had 8 consecutive years of success in shared savings. Performance year 2020, which, as we all know, was during the absolute height of the COVID surge, is going to wind up being the largest year of shared savings ever generated by the ACO. That is a tremendous accomplishment of our clinicians, of our ACO team for going into the facilities, working with facilities, keeping up the communication during an incredibly challenging period for individuals getting into the care that they need. The COVID utilization and related policy changes did have a major impact on this. COVID expenditures are excluded from the shared savings calculation, and then CMS made a number of other policy changes that ended up increasing our quality scores and doing other things that allowed us to earn a substantial amount of shared savings. The total over the life of the ACO has been over $67 million in shared savings to the Medicare program, and earned performance payments to Health and Hospitals and its partners of over $35 million. This will end up being the largest distribution, as I said, ever to the clinicians in our ACO, which is something they definitely deserve after the year everyone had in 2020. However, as we'll go into later, the prognosis for 2021 is a little different. So what we are doing, because of the large amount of shared savings this year, we have worked with the ACO's board to defer $2.7 million of the shared savings that could be distributed this year for next year, so that we are sure that our clinicians will have shared savings next year. But all in all, a tremendous record of success for 2020, and we will take you through our plans for the future. So next slide. This is just a little bit on the quality scoring in 2020. Again, there was CMS's extreme and uncontrollable circumstances policy that gave us full credit for a number of key quality domains. But I think all of these are a great record of success given the challenges that everybody had. We had outpatient care in person largely shut down for many months of the year. People stayed away from our outpatient locations for a lot of the year. We stood up a telemedicine capacity that was never really there. So to be able to reach even this level of quality scores in such a challenging year was quite an accomplishment. So looking ahead to 2021, the story is quite different. We have seen utilization come back in some interesting ways. We have seen the CMS policy changes fade away in large part, though not entirely. And Health and Hospitals overall revenue cycle and IT changes have really taken hold over the past year and a half. And so as a result, looking at it now, we project that we will not be earning shared savings in performance year 2021, but we will not owe CMS money. There is a corridor of $411 on either side per beneficiary. You have to generate more shared savings than that to earn shared savings back, and you have to overspend by more than that to owe money to CMS. And throughout the year, we have been right in the middle of that range, and that's where we see ourselves right now. So that is a new development for us in the ACO, and I can take you through why it's happened and what we are trying to do about it. So the 2021 challenge, I think, is really driven by the post-COVID patient acuity and some of the delayed care that we've seen. It's reflected in those utilization patterns. And then some key program design issues with the ACO program that other ACOs around the country have felt, but are uniquely detrimental to our ACO and health and hospital system in ways that I'll take everyone through. Overall, right, biggest picture, our ACO and our health system continues to spend less per patient than regional and national averages. We're delivering high quality care, and our hospital admissions are lower than 2 years ago. They continued to decline. The thing that is very different about our ACO is just the sheer growth in the cost per hospital admission, and in the case mix index of our patients, how that has changed. But overall, right, our ACO, if you look at the very bottom chart, we spend through Q3 of 2021 about $13,000 per beneficiary. The regional average is over $17,000, almost $18,000. So we are significantly less expensive than others in the region and nationally, which is quite a thing for a New York hospital. And then, but the difference in how our spending has grown in recent years, even as the number of hospitalizations has gone down, is pretty dramatic. You see that in the second line of the top chart. Average cost of hospitalization has gone up 44% in 2021. And really what that is driven by, as we talk about on the next slide, since 2018, when our benchmark was set, we have rolled out Epic, and we have made dramatic changes in capturing and documenting the severity of illness of our patients, the risk of our patients, and in capturing and billing for the revenue we're entitled to across the system. So the ACO program is built off of a benchmark. That benchmark was set based on pre-Epic conversion and revenue cycle data. Our benchmark is an average of the 2016 to 2018 expenditures in the Medicare program across our system. So it's based on years when our billing was significantly less developed than it is now. The calculation of whether you can earn shared savings is based on that historical benchmark, and then two other factors: Medicare's overall growth rates around the country and around the region, but most importantly for our purposes, the changes in the risk scores, which is meant to account for the severity and the case mix index of the patients. In the ACO program around the country, that's capped at 3% per year, which in many ways is a reasonable number. You'd think many private systems and other ACOs push that number up code, try to artificially inflate the risk of their patients. Our change has just been in a totally different universe than that. We have a 40% increase in our case mix index at health and hospitals since this benchmark was set. Now, that is dramatic, and it is because of our significant improvement in documentation, our move to Epic, and changes in our billing practices. So this formula and this benchmark calculation we are seeing in 2021 is a struggle for us and is not working for us to generate shared savings. So it's a key development, and one we have to look at very, very closely.
I'm sorry, Matt. It's between 2018 and 2021. Has the change in risk scores been incremental, or I saw the big change, the 40-something% change. Was that between 2018 and 2021, or just 2021?
The 40% is over the 3 years, so it's been incremental, and it really does tie to when Epic came in. As different hospitals rolled out Epic, the case mix index began to increase. Our last conversion, as you know, was early 2020, and then as we've gone on from there, it's increased across the board. Frida, yeah.
So and maybe you're going to get to this, but so some of this, our ability to perform is because of the benchmark. That's what I'm hearing, right? And the benchmark is pre-Epic, and as we've all talked about, the CMI has improved and increased. But when will we have a new benchmark set?
That's one of the design challenges of the ACO program. There is not a natural methodology to update your benchmark. This risk score adjustment is really the practice for doing that.
So,
Go ahead.
yeah. So what you're saying, if I understood it correctly, is that our patients are becoming more complex, so 40% increase in CMI, so you spend a lot more money on them, but they only allow you for a 3% increase on that, to take that into account, right?
Correct.
So do they have a mechanism by which you can tell them that this is a little bit, the word that I would use would be ridiculous?
Yes.
I mean, is there a way of conveying that information? Because it's very obvious that, the growth is so high that.
Yeah, there are formal and informal channels, right? So there are notice and comment periods for rulemaking and guidance that CMS puts out on the ACO program, which we've worked with our trade association to comment on. But given the scale of this change and the dramatic shift in our 8 years of shared savings to what we have now, I think, Deb Brown and I have talked about this. It is worth more direct one-to-one conversations about this. Again, given the performance in 2020 financially and clinically was excellent, but this year of COVID and the removal of the COVID utilization hit a little bit of this last year. But it's a dramatic change, and the CMI increase last year was not just driven by COVID. It's a sustained thing for us of capturing more accurately how sick our patients actually are. So it is going to warrant a more direct one-to-one conversation with CMS about it.
Hey,
Okay.
Hello. Hi, it's Shadi.
Shadi,
I have
Go
a
ahead.
question. So you said earlier that the 40%, how much of the 40% do you believe is better documentation? So for example, if I went back in time when the benchmark was set, and let's imagine that we had Epic then and you had the same level of documentation, are you saying really that the benchmark got set with sort of like imprecise data and that it would have been different? Or is it a mix of documentation and the patients actually truly becoming more complex? I'm not totally clear because I was hearing different things over the last few minutes.
It's a great question. And yes, it is a mix of things. I think the clearest way to put it is, I don't have the numbers at the tips of my fingers, but pre-COVID, as our documentation improved, we certainly did see the case mix index go up significantly, double digits. So there's an amount of this that happened pre-COVID. Since then, we have seen our patients be significantly sicker, delayed cancers, lack of follow-up on key chronic conditions that has led to longer and more acute conditions. So it is, as you said, a combination of both.
Okay.
And Shadi, I'd like to just reinforce that we did spend tremendous efforts with each facility and each service, improving the documentation. We actually had an outside consultant who was reviewing our charts very closely and giving the feedback. So it's not a binary either or. I have to agree with Matt. There are very serious efforts, significant efforts looking at our documentation. And of course, our patients through the COVID pandemic were very complicated and complex and ill. So combination of both.
Yeah, I would just highlight one other thing on this slide for the boards that should be of interest to the board, I hope, and is of interest to me, definitely. Some of these key design factors are not relevant in our other managed care value-based contracts, right? So we have, beyond the ACO is 10,000 members. We have 700,000 members around the system who we are at risk for, but these design features have not been present there. And as a result, we continue to generate meaningful shared savings and surplus in our Metro Plus, Health First, and other value-based contracts. So that's just a key feature, and I think will be part of our discussion and advocacy with CMS. Okay, next slide. We have.
I'm sorry, could I interrupt just one more second on that piece? So just so I get a little more clarity, so I understand better, the increase in our documentation, that's basically led to increase in our DRGs, and so therefore, in theory, the hospital end increase its revenue significantly on those cases, which means, of course, the ACO end. Is that correct? I just want to be sure I'm correct conceptually on what's happening here.
Correct. Yes, that's a key part of it. Dr. Stevens will talk a little bit more about, we have seen, and we have seen patients be sicker and patients with high utilization. And we, regardless of whether we're in the ACO program or not, need to do everything we can to help those high utilizers get healthier, use our system more efficiently. But that major increase in billing, as we have looked at it, is the real driver of this elimination of the shared savings for 2021. So on the next slide, we just talk a little bit more about the risk adjustment piece. I don't need to dwell on it. I think as Dr. Pagan said, is a technical term ridiculous. That we have 40% case mix index increase and a 3% cap, but there are many reasons it's problematic, right? Our risk scores are going up beyond 3%. It can penalize ACOs with complex beneficiaries. Overall risk adjustment methodology in Medicare has problems as well. We don't think it adequately captures socioeconomic factors, other frailty and functional status issues, and chronic conditions that require more intensive ongoing care. CMS has heard this complaint from other ACOs and other systems over the years. They, I think, understandably, correctly argue that having no cap or a really high cap would cost the federal government a lot of money and might reward people who were upcoding or inappropriately increasing the coding intensity. So they have thought historically that the 3% cap represents a reasonable balance. I think we are a good example of why it might not and what other thinking they need to do about that. So we will have those conversations and keep the board updated on them. But to turn to David, the key approach we're taking is, sorry.
Excuse me, can you do the minutes on the resolution for Dr. Stevens?
Yeah, thank you. So let me jump in and so let's approve the minutes. Next on the agenda is the adoption of the minutes of the HHC ACO annual membership meeting held on January 28, 2021. Are there any questions or suggested changes? So let me then ask for a vote. Dr. Katz, approval of the minutes. You're on mute. But I think I read your lips saying yes. Dr. Calamia,
Yes.
Dr. Shamani,
Yes.
thank you. Philip,
Yes.
Scott,
Yes.
Robert,
Yes.
Sally,
Yes.
Rita,
Yes.
Anita, I don't know if Anita, okay, and Jose Pagan, yes. So the minutes have been approved. And let me then also, next on the agenda is a resolution for the annual election of the officers of the ACO. Mr. Seeger, do you want to read the resolution?
Happy to. Authorizing that each of the following persons be elected, effective immediately, to serve as a director of HHC ACO Inc., the ACO Board of Directors, in accordance with the laws of the state of New York. The individuals are Mitchell Katz, Matthew Siegler, John Ulberg, Andrea Cohen, Gary Calcutt, Nicole Jordan Martin, Jasmine Moshapur, Richard Becker, Warren Siegel, Daniel Napolitano, and Hyacinth Pert.
Okay, thank you. Any questions or comments? So let me ask for a vote. Dr. Katz?
Yes.
Said yes.
Oh, yes.
Dr. Calamia?
It's a yes.
Yes.
Dr. Shamani? Yes. Philip?
Yes.
Scott?
Yes.
Robert?
Yes.
Sally?
Yes.
Rita?
Yes.
Jose? Yes. So resolution passed. Thank you.
Great.
Now we go to Dr. Stevens.
Yes, I just to intro Dr. Stevens, I'd say the first half of the discussion has been largely financial, right? That's part of my responsibility, of course. The two ways we will return the ACO to shared savings is either to have an adjustment. An adjustment to that risk score process, or to make improvements on our per beneficiary spending. And we have some key strategies to do that, that will also improve the health of our patients that Dr. Stevens is.
Just, and Dr. Stevens, just before you get started, one comment that I wanted to make. I like how you explained how we have several contracts now that covers 700,000 lives or whatever, that these issues don't come up. And I think being able to explain to CMS that, look, I mean, 10,000 compared to 700,000, it's not that the ACO is not important, it's incredibly important, but you'll get a lot of questions asked
Yes.
by the board when these things come up. So I don't know if that helps you sort of like frame it when you talk to them.
I think it will.
Because I've seen that at discussions, for example, at the state level, when they want to get different people involved in value-based care, and I don't know, may help. Okay, thank you,
I think it will. Thank you.
Dr. Stevens.
Dr. Stevens.
Thank you. And just coming off of that discussion, how much of this represents the way our performance is, financial performance is calculated. Regardless, 2020 did a lot of harm to older patients. We know from a national study that the number of older people over 70 considered homebound more than doubled from before 2020 to after it. This is the number of people who go out of the house less than one time or less per week. That's highly correlating with poor prognosis in a lot of ways, longer hospitalizations and falls. So while I hope that our patients aren't actually sicker, I think we do have to realize that we need to do more to take care of our highest risk patients. So just we know on this slide, we know that a relatively small percentage of patients account for a disproportionately high amount of the cost, and that correlates with the amount of admissions. If a patient has been admitted twice in a calendar year, our own data shows that patient is over 40% likely to have a third or more admissions that year. That's an incredibly high number. And so that group of patients with 2 admissions are in a special category. And we think there's probably more than just the medical illness that's leading them to those repeat admissions. It's probably the medical illness plus a number of social factors. So that group, which comes to about 200, is really what we focused on in the last quarter, hoping not only can we reduce our expenditures, but can we learn who these patients are, what are the common barriers they have to achieving their highest health status, and what can we do about it? Next slide. So this is a model that we've presented earlier in previous meetings, but basically encapsulates what we think. For the large majority, the very large majority of patients, the primary care team, as it is, does a great job of working with the patient and keeping the patient in a good health status and keeping them out of the hospital. You see in the top purple circle this year, late in the year, we added community health workers to our primary care team, which has been a great help to all our patients, but I can say especially to our highest risk, highest utilizing older patients. For this group of patients to achieve their best health, they need more clinical partners. And as we dug into the individual patients who make up our highest utilizers, work done both by the central office ACO team as well as the ACO team in each of our facilities, 5 themes emerged as needing additional attention to help these patients stay their healthiest, stay at home, helping them benefit the most from the care that we provide. First was urgent access. This was a little surprising to us, but we found that a lot of patients will be getting the right care in primary care, but in between, if they get sick, they just go to the emergency room. And some of that is because they live alone, they don't have somebody to bounce their ideas are, they're anxious. And because they know the emergency room will provide that care, they're confident in that. So what we've done is we've introduced virtual express care to them. This is not a new program for H&H, but it's something that this group of patients largely is unaware of. And so getting them to use virtual express care for intercurrent illnesses to help them stay at home is just something that I think we can really add to their care team. Virtual express care has about an 80% rate of taking care of the patient in the home and avoiding having them come into the ER. So we're hoping that will continue to grow. Social support, probably the single biggest challenge for this group of patients. And sometimes social support is just social isolation. Very often these patients need help with their ADLs. They simply can't take care of themselves, and the benefits they've received aren't sufficient. They can't make it to the bathroom themselves, but they only get 4 hours a day of a home attendant. Well, what are they supposed to do for the other 4 hours? A very common problem. The CHWs have been starting to work on this. Home care has, especially the social work of home care, has been helpful. NILAG, our legal partner that we contract, has an arm focused on social supports for the elderly, and so we're really kind of pulling them very actively into the care. Home nursing, many of our patients would qualify for home nursing but aren't enrolled, and so we're trying to maximize use of our home care services for these patients, especially when there's a skilled need that really is making the difference between that patient getting healthy or not. Wound care comes up again and again. And so we've been active in that. Transportation is a new area that we've started partnering with the H&H Transportation Office. Straight Medicare without Medicaid does not support good transportation services for patients who need them. And we found many patients are telling us that that's a barrier. And then the last, which is kind of where do we go from here? Many of these patients will have long-term care coordination needs. Their ability to navigate their own care is such that it's not something we can train them to do and then they become independent. That's another area that we're just going to start to look into. Next slide. So this goes into a little more depth about what we engaged in for the fourth quarter. Every single patient in that top 200 had an evaluation both by the ACO central office and by their clinical teams. And every single one was referred to home care for a nursing and a social work, as well as a rehabilitation evaluation. And everyone was referred into our community health worker program, the public health core. For those not aware, the public health core program is something that just really came up right around the fourth quarter of this year. Very fortunate timing for us. The public health core is made up of community health workers formerly working with test and trace. They target social support, social determinants, as well as supporting the patient getting the care they need and learning how to do this for themselves. Are they getting their medicines? Are they taking them? Other aspects of self-management, and they're embedded in the primary care, so they're actually day-to-day alerting the primary care team of what's going on. This is set up as a 90-day program. It's still new. Very few of our patients that have actually hit the 90-day time period yet, so we'll see how that goes. Any questions on these specific interventions before I move on?
You want to go? We want to finish. I have a question for you actually, but I'll do it at the end. So the last few questions at the end. Can you keep it very brief, like a few more minutes, a couple more minutes?
Yep. So this is the heart of what I want to talk about. The rest can go quickly. Next slide. So this is what we found. This is the results so far. We were able to fully assess 107 of the 200 patients. They agreed to be assessed, and they were actually still living at home. Some of these patients were no longer living at home. We found 120 unique barriers in those patients, and we went to work with them both downtown at the primary care teams and with our clinical partners. And you can see the most common barriers at the bottom: challenges with ADLs, with medication self-management, transportation, engaging with primary care, difficulties affording their medication, and wound care. And in most of the categories, we were able to get most of the needs to the green, to the point at which the barrier is really completely addressed one way or another. The ADLs is a more challenging one, and that's still, we have a lot of patients that we're still in the yellow, meaning we're working on it, but we have not yet addressed the needs. So what we learned is that even though these patients have been engaged in our system for a while, there were a lot of unmet barriers. And we did learn by pulling in all our different partners, we can meet most of the needs. The transportation is still yellow just because we just in recent weeks unveiled kind of what our program is. We can move forward. This is just a flyer that we shared with all our patients. Both we mailed it to them, and when home care went into the house, they shared. They weren't getting any kind of marketing materials that explained to them what's available in between appointments. Our contact center can provide a lot of support. And for acute illness, Express Care or Virtual Express Care can do this work really well. And we're partnering with Virtual Express Care so that when one of our patients calls, we get alerted, we make sure the follow-up happens. We're actually mostly just watching because the primary care teams are also getting this alert and they're acting on it. Next slide. This is just about the transportation program. For straight Medicare patients who don't have Medicaid services, we're partnering with the facilities to identify who needs the services. We are funding that transportation using car services and a vendor called Sentry that's already established within our system. Next. The annual wellness visit. This is something that we've been working on for well over a year, really looking upstream. How do we find out the gaps in ADLs, fall risk, hearing loss? How do we find that out upstream? Medicare has something called the annual wellness visit that hasn't been implemented in H&H, but it should be. It's really all interventions that CMS recommends based on expert opinion, and CMS actually does pay for it. We've spent a lot of time building this out in such a way that it partners with our nursing teams, our PCAs, to get all the relevant screenings done, and then the PCPs, with those screenings in mind, have a decision support mechanism, so they're guided to do the right kind of interventions. And it's been implemented already in 7 of our geriatrics practices. Our plan for 22 is to implement it in all of primary care. Next slide. So this is just this is the Epic screen. It's actually a screenshot that shows the modifications from business as usual in Epic that support the nursing assessments, the PCP interventions, and the documentation. Move forward. And 22 is basically for the wellness visit, or we expand that, for the priority work to continue what we're doing in uncovering these barriers and continue to develop partnerships with home care, virtual express care, and build some others, and then start to look at innovations that get at these barriers in ways that we haven't been able to get to, especially the social barriers. We have a home-based primary care program that's already running at Kings County with something we talked about at our last board meeting was using video visits. Can we support distance care for this group of patients that often has barriers to technology, but maybe we can work on making it easier for them to engage in video visits. Subacute rehab is something that other ACOs have worked on, and I can stop there. And partnering with BH is an important area. That's it for the programmatic work.
Thank you. Thank you, Dr. Stevens. I have a question, but before I ask you a question, I want to say something before I forget, which is like, I think you and Matt and the whole team at the ACO is doing a wonderful job, and COVID has been tough. And I know that when you're in front of this audience, you want every year to increase in terms of the amount of savings that are generated, but we're on this for the long term, the long haul. So it's very impressive, the fact that I wouldn't let rules that don't adjust at the same speed that we need to cloud your thinking on how to improve the care that we provide to our patients. So my question is, these patients, these folks cost $120,000 per person. I always wonder, like, if you have somebody that just navigates this person, meaning by navigation, I mean somebody that keeps track that all those things that you show there in the model are followed. I don't know if you've thought about something like that. It's almost like if for $60,000, if I had somebody that took me to different places and reminded me, take a pill and do this and do that and manage a group of folks, that could make I wonder whether that would make a difference. I don't know if that could make a difference, but
I think we will find out from this, right? Each of these individuals has some version of that, right, David? I'd say, I mean, our community health workers do a good amount of that work. The help from home care does that as well. But the point you're making, should it be a single person?
I think a
through the
person
length of the
should
year?
call me every day at 9 a.m. and say, are you having problems making your appointment? If not, I'm gonna do it for you.
Yeah.
And I have 30 minutes to do it. And then the next day, how are things going? So the pharmacist giving you a hard time, and then somehow they have a report of some sort so that you can pinpoint. It's like nobody owns the case in a way. That's the way it feels.
I think that's a great point. I mean, we looked at the medical care, and we actually went in with a bias that these patients need modified medical regimens or workups, and we didn't find that. We found they were getting good care from their primary care providers, from their specialists, but they weren't able to navigate in between visits or sometimes even make it to the visit. The community health worker program is set up with a caseload of 20, which I think is the right size. I think 20 is enough to make every phone call needed to every patient every day. We're listening to the community health workers, what they're telling us, and learning from them about what's needed. And I agree. I think time will tell whether, our hope is that after 90 days, the patients will learn to do this for themselves. And some of the interventions have brought in family members who previously have not been involved and have really taken over that care coordination role, which is wonderful when that happens. That's a lot of work to make that happen. But if it works, there is some independence coming after that. We have to see and monitor these barriers, and are they really resolved in a way that they stay resolved, or is that single person needed almost indefinitely?
Thank you.
I think one other just key thing along those lines is the learning in 2022, I think, will largely be how do we get ahead of those next 200 people, right? Because there will be a lot of overlap from the 200 sickest people who cost $120,000 last year and next year, but there will be new ones. And the speed and nimbleness with which we get an alert of someone being admitted to the hospital for that second time, or whatever the trigger we set is, the 2 hospital admissions has been a pretty clear one for us. After the second hospital admission, how do those resources surge into that person to prevent them from the 3rd, 4th, 5th admission? I think that will be a key and a new learning and development this year.
Any other questions or comments from board members?
Yeah, I just actually a couple of things. One relates to in the appendix that you had sent, and that's relating to the total number of members, beneficiaries that are aligned or assigned to us, and it has dropped significantly over time. I'm just wondering, what would be the rationale for that? Why do we think? I mean, looking at, looks like 2013 we had 12,369. We were down to 9,268. It looks like in 2020. Because I'm just wondering too if that doesn't tend to have an impact, because unfortunately, sometimes the sicker patients remain with their providers in the system, as opposed to those perhaps less sick who have more ability to sort of transfer to different coverage and so on. But just wondering if that's had an impact and whether or not something we've addressed.
That's a great question. It probably has had some. The attribution of the assigned beneficiaries was really reflective of just the utilization in our system, right? In 13, 14, all the way up till 2019, the attribution was retrospective. So we would find out at the end of the year, based on how many people had come in and how frequently they'd come in, if this patient was in our ACO or not. In the middle of 19, you see the two columns where we went from 11,000 to 9,000. At that point, we switched in a different track in the ACO program to get a prospective attribution. So, and you see then from 19 to 20, it's gone up a little bit as our utilization has gone up. But it's really reflective of how many Medicare patients are coming into our system and how frequently. So I think, that overall trend in declining utilization was something health and hospitals have experienced for a number of years. And we have seen it go up a little bit in 2020. And so the numbers have gone up a bit, but you are right. That small sample size, for lack of a better term, does make it complicated and make some of these outliers, I think, disproportionately skew our costs.
And two other quick things. I'm sorry it takes time, but end of life care, palliative, hospice, so on. Have we been utilizing that? How is that? How does that potentially impact?
Yeah, I can take that. So we know, and we've known for some time, that our H&H patients are less likely to engage in palliative care, much less likely to engage in hospice compared to national averages. And I think that goes along with the populations we treat. And so it's a challenge, but it's a challenge we have to meet. To help somebody engage in palliative care really requires, from what we've seen, that patient work with a provider they trust and they've known to take that advice about either switching the direction or just introducing palliative care. And so I think that's work that we have to start doing everywhere, that bringing it in early. From the hospice perspective, which is just a slice, we learned from the pilot home-based program at Kings County that we had a much more effective, much higher rate of getting appropriate patients into hospice if they first had enrollment in the home-based primary care program, where a doctor came to their house, met with them and their family over time, and they were much more likely to accept the transition to hospice. So I think those are really important. I don't have a quick answer for them, but there's no question that they're really essential ingredients to make sure patients get the right care, not just kind of reduce hospitalization, but make sure that they're getting the right symptomatic treatments and that they are living their best life.
Thank you for that. And last quick question, Matt, with respect to the community health workers, they came mainly from test and trace. What is the impact now that we're seeing this big upsurge again? Are we having issues now with being able to have people from test and trace coming over? I'm just curious if that's going to be interfering so long with the plans we thought we had as we thought we were turning the corner.
I talked to Ted, Matt, I talked to Ted today just on this issue. And we're okay for the time being. Vince, it's the rise though was very fast. So we are now trying to get additional people who will do contact tracing, and we may short term have to pull some people back, but we're all hopeful that this is just a short search and we're flexible enough. Ted's built an incredibly flexible operation so people can move in and move out as we need it. Sorry, Matt.
Nope,
Thank you.
Okay,
I know, just very quickly, I know Mount Sinai, for example, has a visiting doctor program, and they have a social worker, they have a nurse, they have a whole team, and it's been going on for some number of years. Maybe we never do this, but whether we exchange information or get some sense of what their patterns have been like, or how that model has worked, for them.
Yeah, I haven't personally talked to them. David, I don't know if you talked to them about the
I have.
primary care. Yeah.
Yeah, I spoke, their population health officers over their ACO, and I spoke with them just a couple of weeks ago. They don't have data yet to show whether that makes a difference. That their home-based primary care program has been in effect for over 20 years. And their ACO doesn't have the ability to determine whether it's made a difference in terms of hospitalization. It does, putting services into the home does seem to be where everyone's going, and whether those services are doctors or social workers. One thing that we're thinking about is to put a community health worker into the home to focus on the social part, and then facilitate a video visit with their PCP to see if that kind of, is a kind of an effective way of going there. But I think that the relationships that are built by getting into the home are really critical. And I think it's the key to what our social workers have been doing from home care. So.
okay, thank you so much. So any old business come before us, or new business? Is there no further business? I declare the meeting of the HHC Accountable Care Organization, Sole Member Annual Meeting adjourned. Thank you.
Thank you. Thank you.
Thank you so much.
Thank you.
Thanks, David.
Yeah,
Bye-bye.
Bye-bye.
there are all these models now that, what is it, hospital at home models.
It's been going for. I like that.
Picking up now.
It's a very good one.
I was at the part of the Mount Sinai program, or my mother was,